Hey guys, so today we're going to be doing salivary gland problems. As always, poster is in the link below, so feel free to download it. The way I categorized it was on problems that are associated with each gland specifically. So with the intention that if we were to get a question on, oh, give me a differential diagnosis of a lump found here. So if you, obviously it could be many other things, but if you're going to talk about the salivary gland lumps that present here, you're thinking parotid gland ones, therefore you're thinking these ones only, and then you can take it from there. So if you get swellings here on the side, you have the parotid gland ones. If you have swellings in the floor of the mouth, you have the sublingual submandibular ones, and then if you have swellings on the lip, like inner aspect of the lip, buccal mucosa even, but mostly hard palate, then you're thinking minor salivary glands. Okay, so just quick heads up, there probably will be a few cuts throughout the video just to make sure that we're categorizing it perfectly or as organizedly as I can. Okay, so I'm going to do one cut here. Right, so if you have a look at the poster, everything in the brown boxes are neoplasms, so it could be the ones in orange are benign, and then the ones in light green are malignant. I'm going to do that separately because that's just a different topic. However, the rest of the video I'm going to do it on just lumps that you would find based on location. Okay, so we'll start off with the lip. That's the most common one. It's the mucoceles. Okay, so mucoceles can be of two types really. So a mucocele is a cyst full of mucus. So there's the two types. There's the retention cyst and the extravasation cyst. So the extravasation cyst is the more common one. This is the one with the biting of the lower lip. You bite on it, you damage a duct, you break it, and then saliva comes out of it, and then your saliva is supposed to stay in that duct. Now when your duct is ripped open, saliva comes out, the rest of your tissues are like, this doesn't belong here, and so it creates like an inflammatory reaction. And then what happens, you get infiltrate, like so lymphocytes and whatnot, they all come over and then they create like some sort of granulation around the saliva, and that's what gives you that cyst-like appearance. So I think an important thing when you're going to write extravasation cyst is not really a cyst, because a cyst is a fluid-filled cavity lined with epithelium. So there's no epithelium in this one because it's just like within the tissue. So I think that's the main point about extravasation cyst. So it's caused by trauma. There's no epithelial lining, and the best way to cure this, so sometimes it will just go, it'll rupture itself and it will just leak out. But then if a patient comes, it's like, okay, it's been happening so many times and it always happens in the same place, probably because the trauma is happening in the same place, and then also because it's the same duct that's like not healed. So what they can do is that you can come, you can excise it, laser it, cryosurgery it, but the point is to remove it without bursting it, because if you burst it, then you just cause, again, saliva to spill into tissue where it doesn't belong, and you'll just create another mucocele over there. So it's really important that you take it out entirely. If it's a persistent problem, then you can just excise like the whole, that minor gland. Retention cysts are very similar. Again, they occur typically in the lower lip. You can get them in the parotid, but we're going by location. So what happens in this one is it's more of an obstruction. So you get pooling of mucus within the duct, and it stretches, it stretches, it stretches. So if you were to ever see it like under a microscope, you would find that there is an epithelial lining because it's a really thin duct that's been stretched because of the mucus. Now, why does mucus pool behind? It could be because of a stricture, it could be because of trauma, and we'll get to that afterwards, strictures and calculi afterwards. Then we have the ranula. So this is usually associated with the sublingual gland. So this is a type of extravasation cyst. And what happens, same thing, but it happens in the floor of the mouth. So you get a really big bulge like under the tongue, and the patient's probably complaining because their tongue is like, their mouth is just full. So it pulls, same thing, inflammation, creates a cyst-like appearance, and then what happens is that it can get really heavy, and then it can kind of fall through your mylohyoid muscle, and that's when it starts presenting here in the neck, and that's when you call it a plunging ranula that's gone down into the neck. Right? Treatment is marsupialization, and then if necessary you can excise the entire sublingual gland. Okay, so the next two that I want to talk about are strictures and calculi. So strictures are caused mainly by trauma, so whether it be from the inside because of denture clasp kind of hitting the parotid papilla, which is traumatizing the duct, or from outside, let's say you had an excision, a parotidectomy, and they severed a duct. Again, in the process of healing, you get fibrosis, and then the fibrosis causes the duct to constrict, so causing a stricture. So on imaging, so cyalography, you'll get sort of a normal duct, and then it will pinch and then open, and then if there's another one, pinch again, and that's where you get that string of sausages metaphor. And treatment-wise is ballooning, okay, so dilatation of the duct, which is I think very similar to stenting arteries. Anyway, so calculi, typically found in the submandibular region because I think of that collection of calcium and phosphate ions because your saliva pools there. And what happens is that the saliva inside the duct gets calcified and it becomes a stone, so a cyalolith. And the stone, what happens is that it blocks the duct, and then with strictures and with calculi you'll find that on expelling of saliva you get intermittent swelling and intermittent pain, and this is just because it's difficult for saliva to go through, and it's just a difficult path than normal. So it causes the swelling and the pain, and this is called mealtime syndrome. So any thought of food, sight of food, you start to salivate, but because it's difficult and you're probably putting a lot of pressure, it will swell and it will cause pain. Okay, so both of them are associated with mealtime syndrome. Strictures will typically happen, I think, in the parotid just because that increased chance of trauma, and the calculi will typically happen in submandibular region, so floor of the mouth, and that's because of the pooling. Now, in terms of visualizing the calculi, because it's radiopaque, because it's calcified, you could see it on a normal radiograph, but sometimes it's not completely calcified and it's just a mucus plug and you can't see it, so you can use a cyalogram and you will see like something is stopping, or like there's a round bulge. Now, treatment-wise, you could just pass it. It will pass through normally if it's really small, but then sometimes it needs a little help. You can milk it out, and then also you can tie a stricture behind and then cut the duct and then take it out. However, make sure you mention that stricture, because otherwise it can just pass backwards. Or you can use any of those lithotripsies, so I think it's like that really ultrasonic shaking, breaks it down into tiny pieces and then take it out, or the basket retrieval, stick a little basket in, grab it, pull it out, all like very, very minute like surgical procedures. Risk of calculi, so it can happen once, but then sometimes it'll happen again and again, and it can get really irritating and it can get infected. So what happens is that it's like calculus on our teeth, so it just adheres bacteria and adheres like more plaque. So the same thing, it's a calculus inside the duct, it's rough surface, so bacteria sticks to it, it gets cozy, and then it infects and it inflames, and then you get like recurrent infections. And let's say, fine, the first time it gets fixed, but then you get infected again and again and again, and then eventually what you end up doing is just excising the entire submandibular gland. It is a bit dramatic, but they do that. And then on cyalography, when it comes to these recurrent infections, you would find that stone, lots of like, what do you call it, dilatation around the stone, and then fibrosis in front, which is caused because of that inflammation. You get sort of fibrosis and just thinning of the duct. Okay. So moving on to infections. So we've talked about salidinitis that can be caused by calculi, but you can get other bacterial infections, so that cause bacterial parotitis or ascending parotitis or ascending salidinitis. All the same thing. Whole point is that these are patients who have dry mouth or Sjogren's, and they're not expelling saliva through their duct. Now, it's the same thing like how we flush our lines so that we don't get Legionella. If you're not flushing that duct, you can get a bacteria that ascends upwards. So you'll find that they'll get fevers, they'll get lymphadenopathy, and if you press on the duct, you can actually expel some pus. If you culture that pus and gave it off to the lab, they'll find either like Staph aureus, strep, or other sorts of anaerobes, and then you can give an antibiotic, so it's like to kill that bacteria for treatment. Now, you can also get mumps. So mumps is caused by, I think, the paroxysmovirus. I could be making that up, but I'm pretty sure that's right. Now, typically we won't find it nowadays because lots of people are vaccinated. That MMR vaccine, so the measles, mumps, and rubella vaccine. But of course there are people who don't believe in vaccinations. They won't vaccinate their children, and they'll come presented with mumps, which is bilateral inflammation of the parotids. It'll be, I think it's really red, hot, and tender. And sometimes you'll get patients who were never vaccinated before, and they've never got it, and now that they've had it, it will be, so adults that develop mumps, it will be a very severe inflammation, and it won't be your classical presentations. So you'll get potentially a unilateral swelling. So it's always good to rule out mumps or a bacterial infection. Now you can get viral infections, so the HIV-associated salivary gland disease could be unilateral, could be bilateral, but if it's bilateral and in children, it's probably HIV. So a soft enlargement of the parotid glands is usually associated with HIV, of course if there's a history, and on ultrasound you'll find that it's multicystic, so that's why they also call it the HIV-associated salivary cystic disease. Salivary gland.